Hello, everyone. Today, we have the pleasure of welcoming Dr. Celine Bouchard. She is a former clinical professor in the Department of Obstetrics and Gynecology at the University of Laval. She has also participated in numerous studies on women's health and is involved as a co-researcher in studies on hormone replacement therapy during menopause. Dr. Bouchard, thank you for joining us today.
Thank you for inviting me, Dr. Dontigny.
Today, I'd like to discuss something that is a very common issue in obstetrics and gynecology, postmenopausal bleeding. Can you begin by giving us a brief explanation of what postmenopausal bleeding is and what is considered normal and what is considered abnormal?
First and foremost, postmenopausal bleeding is not normal. It is defined as bleeding that occurs 1 year after the last menstrual period. After a year of not menstruating, any bleeding thereafter is considered abnormal. It is therefore necessary to consult with a doctor in order to rule out the possibility of cancer. Endometrial cancers are not common, but all the same, it is very important that we eliminate the possibility.
Do women often experience postmenopausal bleeding?
Yes, statistics show that between 4% and 11% of women will bleed after menopause at some point in their lives. Therefore, yes, it is common. It also accounts for 5% of gynecological consultations. So yes, it is very common to have patients who consult for this reason.
And what are the most common causes of postmenopausal bleeding?
The most frequent causes are not endometrial cancer. So, I want to reassure women of this, even though we want them to consult us so that this possibility can be ruled out. The causes are generally benign. They might include polyps or atrophy. Polyps and endometrial atrophy account for 70% of cases. Then, there is the possibility of a proliferative or secretory endometrium, which is a hormonal issue. Medications that can cause increased bleeding should also be ruled out. We also have to consider the possibility of abnormalities in the reproductive system, of cervical cancer, and of other female parts that can bleed or develop irregularities, like the vagina, cervix, vulva, or urinary tract. So, we need to look at the whole picture.
Dr. Bouchard, since the female anatomy is sometimes misunderstood, could you go over it with us?
Of course, Dr. Dontigny. Let's start with the vulva. As gynecologists, we inspect the vulva for precancerous lesions or cancer. So, we look at the labia minora, which is the non-hairy part around the vaginal entrance, and the labia majora. We also inspect the glands clitoris and clitoral hood. Next, we look at the perineal region, which is the bridge between the anus and the vulva. This area is called the perineum, and we always inspect this area to make sure there are no cancerous or precancerous lesions. Then, we insert the speculum. This is the small ductile-shaped device used by gynecologists to view the cervix and vaginal walls. So, at this point, we are looking inside. We have to remember that the uterus has several parts, the body and the cervix of the uterus. The cervix is the part that closes the uterus. The body of the uterus is where the baby grows and where the endometrium is found, lining the cavity. This is also where we might take a small sample for an endometrial biopsy to investigate for endometrial cancers. Next, there are 2 small tubes responsible for the passage of fertilized eggs to the uterine cavity. And then there are the ovaries, which are palpated at the end of the examination.
Hence the importance of consulting quickly if any bleeding occurs.
It's very important.
What happens during an appointment to consult for abnormal bleeding, Dr. Bouchard?
First, I ask the patient some questions. When did the bleeding start? Was it abundant? Has it been going on for a long time? I would probably also ask if the patient has any medical or surgical history, if she is taking any medication. I would also check to see if she has diabetes, which is one of the risk factors for endometrial cancer. I would also check her body mass index, because if she is overweight, she may be at a slightly higher risk of endometrial cancer. Next, we go to the examination room where I would suggest that she have an endometrial biopsy, which is where we insert a thin tube through the cervix, further than for a cervical cytology, and remove a small piece of tissue from inside the uterus, which is where precancerous lesions would be.
Can you list some of the risk factors?
Of course. So, the older a patient is, the greater her risk increases over time. For example, a 50-year-old patient is at a lower risk for postmenopausal bleeding than a 70-year-old patient. We take it more seriously when the patient is elderly. A history of diabetes or being overweight are also risk factors. In fact, when a patient has a body mass index of 40 or more, meaning they are morbidly obese, they are 7 times more likely to develop endometrial cancer. Early menarche is another risk factor, as is late-onset menopause. Estrogen-only hormone replacement therapy, or tamoxifen, which is a drug given to breast cancer survivors to reduce relapse, also increases the risk of endometrial cancer. I think that about covers it.
Once endometrial cancer or precancerous lesions have been ruled out, what is the normal treatment for postmenopausal bleeding?
If the biopsy shows an atrophic endometrium, this means that the endometrium is so thin that the walls may have rubbed against each other and formed small erosions, which is where the bleeding is coming from. This is benign, so we won't do anything, but we will inform the patient that if the bleeding recurs, a transvaginal, that is, an internal ultrasound will be suggested. This is where we put a small device into the woman's vagina and check the thickness of the endometrium. If the endometrium is less than 5 millimeters thick, no other investigation is required.
Dr. Bouchard, in continuing with our theme of irregular uterine bleeding, I'd like to address the issue of bleeding during hormone replacement therapy. Is it normal or abnormal to have bleeding during hormone replacement therapy?
First, Dr. Dontigny, it is important to note that there are 2 types of hormone therapy. There is cyclic hormone therapy, where progesterone is not administered every day of the month. It is considered normal to menstruate with this form of hormone therapy. Then there is continuous hormone therapy, which is the most popular continuous regimen. If the 2 hormones estrogen and progesterone are taken every day, there should not be any bleeding. But there may be some bleeding during the first 6 months after the prescription for hormone therapy is started, and this is normal. After 6 months of continuous hormone therapy, patients need to inform us if they experience any bleeding. In this situation, we must investigate in the same way that we do for patients who are not on hormone therapy.
Dr. Bouchard, if a patient starts bleeding while undergoing hormone replacement therapy, should she stop her hormone replacement therapy even before seeing a doctor?
No, not necessarily, because most of the time the cause of the bleeding will be benign. Cancer is found only 6% to 7% of the time. So no, I wouldn't recommend stopping ahead of time. It's really not necessary. But if precancerous lesions or cancer are found, then hormone therapy should be stopped.
What are the treatment options for patients who experience bleeding during hormone replacement therapy?
After a biopsy, if the pathologist reports a proliferative endometrium, this means that the endometrium is growing and that the balance between the 2 hormones is not right. Estrogen levels may be increased or lowered, or progestin may be increased. We need to restore the balance between the 2 hormones in order to stop the bleeding.
Dr. Bouchard, there is also an important transitional period to consider, which is the late stages of perimenopause, meaning the phase that occurs just before menopause. This is when cycles start to be more than 60 days apart. Just when we start to think that we may be at the onset of menopause, bleeding may reoccur. When is there reason for concern about bleeding in the late perimenopausal period?
I'd say that a very heavy period or abundant menstrual flow is cause for some concern. This can be measured using a menstrual cup, which is placed inside vagina. It can also be calculated with a pictogram. Images of soiled tampons and pads can indicate if the flow is abundant. But more than anything, it's a matter of patient comfort. If a patient is uncomfortable with her menstrual flow, she should seek medical advice.
But what type of investigation is there to do at this point?
The same thing that is done post-menopause. An endometrial biopsy is suggested because endometrial cancer might be a concern, though it occurs less frequently than after menopause. A vaginal ultrasound, where a small tube is inserted into the vagina to see inside the uterus and determine precisely if the endometrium has thickened, may also be considered. So, we have to investigate.
And in what cases do we need to consider treatment for these patients?
If, for example, a typical endometrial hyperplasia or endometrial cancer is found, a hysterectomy or removal of the uterus will be recommended. If a polyp is found, removal of the polyp will be suggested. If a fibroid is found in the uterine cavity, we call this a submucosal fibroma, which is a small ball in the cavity that can cause a lot of bleeding. In this case, the patient will be referred for a hysteroscopy to perform a surgical removal of the fibroid using the natural pathways.
Thank you very much.
It's been my pleasure.